the new tools that are available, what other factors do you consider when working with an AML patient to choose a treatment approach for them?
The most important aspects are what we call, and this is, I'm glad that you bring this question up, because I feel you have to think of, and that's what we've been talking about, what we call disease-associated factors. This is everything in the leukemic cell, like how does the leukemia look like, how does the blast look like, what changes are there. But the biggest part are what I would call the patient-associated factors, the patient age, the patient performance status, actually the patient, because I think sometimes we forget about it when we just look at all the molecular testings. But even if, for example, there would be a patient with a very good risk leukemia, where I think, this leukemia should respond very well to an intensive chemotherapy. If the patient cannot tolerate chemotherapy, and I see it more often than I would wish for, or patients who are young, who are in a great performance status, but they just cannot, they have family reasons, small children sometimes, that they just cannot be away for so long. This all comes into consideration, So it's really important, because we all work together as a team, and the right treatment for the leukemia might not be the right treatment for the patient. And for most cases, however, I think, and it will only work if one stands with a whole heart with both physician and patient and family, because it's a long journey behind the care that's being given. Mm-hmm. And so this is a joint decision making, and there are different options that can be done. Of course, I would not advise something where I would think there are no chances of success, and so this has to be an open discussion. But it's very often a very tough treatment, and to communicate that and see what are the goals of each patient, that will be most important for treatment decision making.
What types of AML treatment classes are currently available?
Mm-hmm. This is a very good question. So the most classic treatment class is the intensive chemotherapy. This is, and I'm just because people might have heard the name, this is called 3+7 or 7+3, which refers to a 1 week long inpatient chemotherapy treatment, where you get one chemotherapy for 7 days, and the first 3 days you get a second treatment as well. That's why it's called 3 and 7 in here, but it's a total of 7 days. So we have intensive chemotherapy, and there are different flavors of it, but this is usually the backbone. And the second class is what I would call a targeted inhibitor. And here we can look at two different aspects. We have target inhibitors for specific DNA mutations that are found. And specifically, one are called IDH or FLT3 mutations. And these are pill forms that are usually by now combined with a third drug class, which is called hypomethylating agents, that I will go through in a moment. But these are pills that really only work in patients that carry this genetic change. Mm-hmm. But they have very, very low toxicity and very high chances of working. So that's why this testing is so important, to see if one is one of the 15% of AML patients carrying an IDH mutation. 15% isn't low, and a similar rate that carries a FLT3 mutation. And then there is also going to targeted inhibitors, but it's targeted because it is against what I would call a pathway, a gene that is commonly activated in acute leukemia, and this is called BCL2, and the drug is called venetoclax. This is now stormed through the acute myeloid leukemia world just a few years ago, and has been approved as a frontline treatment option for several patients, especially for those who are older. And we know that even patients who respond usually favorably to chemotherapy, some of those also respond well to venetoclax, to this BCL2 inhibitor. The benefit is that this treatment, in many cases, if it works, can be done as an outpatient in here, and has very often lower complication rates. It is actually had so good results that I sometimes, that it seems too easy. So we actually advise patients to still try to get the first time they get the treatment, do it at a center where it's done more commonly, because it is, it's sometimes one underestimates the power of a pill, and it's still a very, very powerful drug. So doing it in a controlled setting, because if cancer cells break down, they break down and can create all sorts of trouble. So, but this is really something for several leukemias that can be considered. And again, then now the third treatment group are what we call hypomethylating agents. The names are azacitidine or decitabine, and they act in a very different way. They try to change the epigenetics, like methylation patterns of the, and this is an untargeted way of the tumor cells. They can be used alone, or very often by now in combination with the targeted inhibitors that I was just mentioning. These are infusions that can be done either over 5, 7, or 10 days, depending on the combination treatment. And for patients, as I mentioned before, that don't respond well to many other options, to those patients with a complex karyotype, this is, for example, a scenario where patients can just receive this as their only therapy.
What about stem cell transplant? You didn't mention that.
Yes, that would be the next one. So stem cell transplant always comes as an option, which I would call as a maintenance therapy. Again, two aspects. We have two different goals. The first is get rid of the leukemia. The second is to make sure it stays away. As soon as the leukemia is in a complete remission, depending on the performance status, the agent, again, multiple different things. It's not an easy decision. At that time, there has to be a conversation, and that always involves a leukemia physician and a transplant physician. Very often, these are different providers that goes through the risks and benefits. Where the question is, if I only continue to do chemotherapy, because it's never only once, you would always have to repeat your chemotherapy. What is the likelihood that the leukemia comes back? And does it outweigh the risks that comes with a stem cell or bone marrow transplant that comes in here? But for many leukemias, especially for young patients and for patients with higher risk, this is the only chance of a cure. That is the most curative and only curative attempt for many leukemia types.
Where do clinical trials fit into the treatment plan?
And that is the absolute backbone we always have to think about. Everything, all the treatment options that I mentioned have been clinical trials just very, very short time, very few years ago. So for every patient that comes to a leukemia or a cancer center, clinical trials will be discussed if they are available, because they will provide us with the opportunity to have even more fine-tuned treatment, either newer agents. And I think what is very important to mention is that all clinical trials that are available would give the option of the best standard of care, and then the hope that if a patient wouldn't be getting any of the best standard of care options that are approved, the hope is that the new agent or added agent in many cases would even do better.
Yeah.
It's also important that there's a lot of additional monitoring during the trial. I think it can be seen in two ways, as two parts of the coin. On one way, it may be additional visits to the hospital or additional blood draws that are necessary to be sure that the medications are safe and that researchers and clinicians can learn about it. But on the other hand, it also gives you this extra bit of being looked after and really getting checked in and out, making sure that all organs are functioning, that everything is just going fine. And many patients appreciate this a lot when they have this pair of extra eyes on them all the time.
Dr. Eisfeld, what therapies are available for AML patients who relapse or don't respond to initial therapy? And is this treatment approach different from those who are newly diagnosed?
Most of the time, the treatments available at relapse are the same available at first diagnosis. Just because we now often know that for example, if you have a molecular marker that, for example, is available, it would act with also relatively high chances in the relapse setting. However, at relapse, the most important thing I personally be doing is to consider a clinical trial, even stronger than in the first line setting, because it means that the leukemia outsmarted current treatments very often. So usually in what we would be doing is see if there is a targeted inhibitor, is there a mutation of FLT3 or IDH, which I would personally always prefer to go in, or an MLL rearrangement now for the new menin inhibitors, where one would go with the same option as if it would have been their diagnosis. But if not, to really consider clinical trials with strong urge.
Mm-hmm. Should patients or should relapse patients undergo genetic testing again? Is it necessary?
Yes, at any time, yes. Because we know that the leukemia changes. And you just can think about it in the ways that the cells that are surviving treatment, they have become smart. You know, there was so much poison, there was so much treatment put on them. And the ones that survive might have acquired additional chromosome changes, additional gene changes. And even if a genetic change has not been present at time of diagnosis, the reason the cell has survived might have been that it has now one of these changes that came up on a later time during treatment, or while the cell was hiding somewhere to come back.